I was asked to talk about risk stratification in adult spinal deformity, which, as you'll see in the talk, sent me in a bunch of different directions, and maybe a little slightly different than some of the talks we've had today, but hopefully you can enjoy it. So the goal is to review risk stratification, indicating the benefit and risks of stratification in adult spinal deformity, as well as to illustrate pitfalls. So I do some work with Health Trust, which is a subsidiary of HCA, on data analytics with Medicare, developing toolkits. So the message of this whole talk is that big data is here. It's not going away, and if anything, it's going to get better. And that's basically how we're going to build risk and outcome stratifications in all parts of spine and in healthcare. And I think it's really important to think about why we're stratifying, what are our goals of stratification, and then the goal of making it usable at the point of care so that it enhances our patient experience and our patient interaction between surgeon and patient, and then to identify the limitations as well as the opportunities in the environment of the point of care. So big data is here. All these companies know what you're likely to buy today, where you're likely to buy it, where you're going to go, what vacation you're going to take, what vacation you want to take. They know a lot about you, and they're selling you things constantly. And there are healthcare companies like Optum and Truven Analytics, as well as Athena, that are now in the business. And they're break-off companies from insurance companies, which are in the business to understand the narrative of healthcare, the utilization and costs. So it's here. Wall Street has done it in terms of risk and rewards and looking for efficiencies in the marketplace. And certainly they've done it in sports. And Michael Lewis, in his book Moneyball, made that very popular. So I picked out two recent risk stratification papers that have been presented. The authors are included in some of the faculty here. And so the goal of this article in the Journal of Neurosurgery Spine was to develop a perioperative predictive model for major complications following ASD. It's a retrospective review of 557 patients, multi-center. Of all the predictors here, and these were the predictors that were in the model. And of note, this was demographic data, medical comorbidities, ASA, Charlson index, as well as radiographic parameters and surgical parameters. So there's a lot of variables in this. Age, leg pain, ODI, numbers of levels decompressed were some of the highlighting predictors. It was quite accurate at 87% accuracy, which is a very good model. And the authors noted that this should aid us in counseling and shared decision-making type activities and surgical planning. The limitations are that it doesn't yet do that for us. So it's a research paper, it's a model, and converting that into a point of care activity that you can share with your patient and come together in a decision is not quite there yet.
It's interesting. So our purpose in putting this paper out was not so much in having a model that you're going to use clinically, but showing that you can develop it.
Yeah. So
that was the thrust of it. So we've got into some initial efforts using data, and it's probably not big data. Big data is billions.
Right.
But the point of this and the NCID papers we put out is, okay, it's doable.
Right.
And it's the direction we could go. So those are very fine pieces. I think that when you look at what we're doing from a research standpoint, that what we're trying to get out of this, should be looking at this, it can be done.
Right.
So what are the next steps?
Yeah. And I think my point is that if we're going to spend time doing this, then we have to have in our minds that we want to use it at the point of care. Yeah. And so go at that from the start. So I picked one other one just to highlight, and this is in contrast. This is all built on medical comorbidities. So there's no radiographic, no surgical procedures built into it, and there's a frailty index. And it was also a very good predictor. It was built off of the NESQIP database from 2005 to 2012 with 1,001 patients, multi-center. Again, it showed not huge numbers like big data like Amazon and those people have, but ultimately Athena and Optum have these databases. And this is a better predictor than age and obesity. An increasing frailty index was a predictor of complications, any complication of mortality, blood transfusions, PE, DVT, and reoperation. Again, this one might be a little bit easier to design a tablet questionnaire for the interaction with the patient or pull it out of your electronic medical record. But So clarity of goals, I think, is very important. Are we stratifying to educate the patient and provider and talk about risks and benefits? Are we there to optimize outcomes and decrease risks and look at observed versus expected ratios for variation in outcomes? Are we doing it to withhold care? Like the conversation we had earlier about the severe kyphotic deformity. Are we identifying patients that are at too high of risk and we want to do no harm to, consistent with our Hippocratic Oath? Or are we doing it for costs? Are we doing it for performance in bundles and sort of more in the model of the appropriate use criteria? I think we should also try to start to explore these stratification models, risk versus outcome. There are some risks with relatively low impacts that we will take on for a better outcome, and then there are risks with a lot of impact that we may not want to take on risk even though there's a better outcome. So there is an association there that needs to be worked out in stratification. And one way to think about this in clarity of goals is to go back to Porter's original article that's been cited over and over, talking about value equaling quality over cost. Costs are easy to get at, or they're easier to get at. Quality is a little bit harder, but if we're going to start stratifying based on risk and outcome, we should talk about how we're doing that. And so in his original article, this is one model that we might go after, which is these 3 tiers, survival or mortality being on the top, degree of health recovery in the immediate perioperative, and I'm talking about this from a perioperative standpoint. Tier 2 would be time to recovery, and then a lot of the stratifications are really in the second part of Tier 2, where they're talking about adverse event and complications. Tier 3 would be more of sustainable outcomes, maybe junctional kyphosis and longevity and non-unions. But looking at in this tiered process and building out stratification models to answer those questions need to be discussed. It needs to be usable and scalable, so build on preoperative data, readily available, routinely measured, reliably measured, affordable, and personalized. And we all have different EMRs. We were talking yesterday that some of the people who are practicing, they have 3 different electronic medical records in their practice alone. And drawing information out of that has to be affordable and repeatable so that it's easy to get at. So this is big data. And I think what we have now that's different than Amazon collecting data on us is that we're actually talking to a patient and trying to make a high-stakes decision, especially in adult spinal deformity where the risks can be 20 to 80%. We're trying to make a complex decision. And where the stratification tools can help us is to help us understand the probabilities of different risks and outcomes. I think the next level at the point of care complicates things in terms of understanding a surgeon and patient's perspective of those probabilities. It gets even more complicated. And then together with these 2 different perceptions, trying to reach a complex medical decision. And I'm going to go off on a little bit of a tangent, but this is the spine surgery calculator, which is out of Dartmouth, and I enroll patients in it. It's funded by Consumer Reports. So this is about degenerative lumbar disease. And so this is me up here, 45-year-old non-smoker with severe neurogenic claudication. I can't walk more than 10 minutes. So this is the story. And so if I have surgery, this graph tells me that I'm going to do better than if I don't have surgery. But I'm not even sure what to make of that. Is that a significant difference for me functionally? The difference between the surgical line and the non-surgical line, and what do I have to give? So how we present this to patients and how surgeons see it versus patients see it is a challenge. This one might be more helpful where you can take modifiable risk factors and have the results change. But again, this is pain score. So is that a significant drop for me as a patient or not? And I'm not sure that these graphs answer that question well. So I think we have a Moneyball problem. And this is the tangent. So Moneyball, the original Michael Lewis Moneyball was about a baseball team taking on data and deciding what players to hire and in a limited budget and what they could get out of it. So they did better, right? They weren't perfect. They did better. They didn't win the World Series. So Michael Lewis has now gone on to write the Undoing Project, which builds and talks about the limitations of big data. And I think a lot of this is pertinent to our interaction with patients. And this is into heuristics and biases. In understanding, even if you have a percentage of, there's a 40% chance that you have a risk of mortality, how the surgeon versus the patient sees that risk and understands that risk is problematic. So these are some basic heuristics, and I want you to answer the question very fast in your mind. So a bat and a ball together cost $1.10. The bat costs $1 more than a ball. How much does the ball cost? Right? Right. So almost everyone answers 10 cents, and it's the wrong answer because your mind divides a big number into a little number, right? And even if you know that that's wrong, it's hard to fight your mind even doing it, right? It just does it. It's useful to us. We estimate. It's an efficient way to move through the world, and most of the time we're close enough, and we can be right for the wrong reasons. So a coin is flipped. You can either land as heads or tails. Which series is more likely? So everyone in this room should understand this more than other people, but most people get this wrong, right? They both have the same probabilities. It's 50% for each one, right? But the gamblers believe that if 3 heads have gone, the next one's more likely to be tails, right? And we all know that's wrong. And the frequency of mundane events are underestimated. The frequency of impactful and memorable events that easily come to mind, we overestimate. So one example to this is, a patient comes in to see you and their neighbor had a PE and a DVT, right? So that patient will classically overestimate in that scenario the chance that that would happen to them, right? Even though that's not true. And confirmation bias was talked about earlier in Dr. Chapman's presentation, which is the patient looked like a really good surgical candidate, right? But there are all these psychosocial issues in the background. And the patient does the same thing. You look like what a surgeon should look like, right? And we all do this. And the scary part about all this is that even when you're aware of all these things, you still do it because it's the way our mind works. And this is the most recent book by Daniel Kahneman, Thinking Fast and Thinking Slow. So the system 1 in this model is the fast, inductive, emotional, and system 2 is a slower, deliberate, logical model. And each one has a role in our lives. It's an efficient way to move through life. An example is loss aversion. We'd rather not. We're averse to losing $10 more than we are the chance of winning $50, right? And his statement that years of academic research say we place too much confidence in human judgment. And I think this is where the stratification tools can really help us, right? But they're just tools, and we still have to, this is part of the limitations of using them. So this is a study that by Dr. Hart comparing patient and surgeon perceptions of adverse events after spinal deformity. And they took 14 ASD surgeons and 16 ASD patients and presented scenarios of 22 complications. So this one was a heart attack, and 3 questions were asked for each complication. How severe do you think the complication is? How would the complication affect your satisfaction? And what impact do you think it would have on your quality of life? And so for 10 of the 22 complications where there was a difference, the patients thought that the severity, the impact of the complication was significantly higher than the surgeon's perception, right? And so this is the challenge of that interaction in driving it down to patient care. So one interesting article was the Seattle Spine score that kind of gets at this. They took another stratification model, retrospective data, 136 patients, had an accuracy rate of 76 versus the original model that we looked at, which was 87. And from that, they found 7 factors that were pertinent in their limited data set. They created 100 random cases from this that they pulled from. And they utilized eight providers. And they created 3 scenarios. The first one was surgeon only. The second one was a surgeon plus the decision support system. And the third one was the decision support only. So the Seattle Spine, this is what it looked like. So on the right side is a high-risk patient, on the right side is a low risk, and on the left side is a high-risk patient. And there are the 7 factors. They're easy to put in, right? And you get this probability of a complication occurring within 30 days of complex surgery. So that's the decision support system. And what they found was that if they left the surgeon alone to review it and use their knowledge and intuition, that they were basically had 50% chance of correctly predicting whether the patient would have a complication or not, any complication. Right? The surgeon plus the decision support got them to 61%. So it wasn't a huge jump, but it was a marginal jump that definitely improved them. Whereas the DS-MOM only was correct 76% of the time. So I don't think this is arguing that we should just give everything off to the computer. right? Because it's still, and this was mentioned earlier today, so much of the patient experience and the patient satisfaction and even the outcomes are tied to the personal relationship with the surgeon and the staff in the hospital. But the decision support tool can improve it in this one model. And the goal is to de-bias and create a consistency of judgment. This is especially true in almost all of our lives on a Friday afternoon after we've had a busy week. And we've seen a lot of clinic. There's fatigue, sleep deprivation, stress, and cognitive overload. And in that situation, the heuristic and biases become much more prevalent. And so the decision support system can help us deal with that. So the message here is that big data is here. It's going to become more and more a part of what we do as companies like Optum and Truven come into our lives, and our hospitals and health systems look to them to create a narrative around what we're caring for, and especially as costs get tighter, right? There's going to be a lot of decisions about who we should operate on and who we shouldn't, and who's going to be in a bundle and who's not going to be in a bundle. And so I think that clarity of goals is important, why we're doing it, why we're stratifying, because that changes what we do. We want to make it usable at the point of care, and we want to understand the limitations and the opportunities that are there that can help us make better decisions with our parents, with our patients, about whether surgery is the right choice for them. And that's it. Thank you very much.